held. So it's an estimation, and it's largely used in clinical practice for monitoring respiratory rate.
Dr. Schaefer testified that the failure to maintain records or charting or documentation was both an egregious and unconscionable deviation from the standard of care. Do you agree with that?
The terms that you describe, I have to say, are not terms that I'm totally familiar with or use, but I would say that it's desirable certainly to keep a medical record for medical legal reasons so that other physicians can be aware of what was administered to a patient and for purposes of billing. But I don't agree that the lack of a medical record in this case contributed to the death of Michael Jackson, no.
Motion to strike, non-responsive.
Sustained. The answer is stricken. Please disregard.
Do you disagree with Dr. Schaefer's statement that it's an egregious and unconscionable violation not to maintain charting and appropriate medical records?
As I said earlier, I think having a medical record is something that's desirable. It's routinely done. There are reasons for recording a medical record, including medical legal reasons.
I'm sorry, doctor. I was asking you do you disagree with Dr. Schaefer's opinion that the failure to keep medical records in this case was an egregious and unconscionable violation? Do you disagree with that?
As I said, I'm not familiar with what the term egregious and unconscionable implies in this situation.
Do you think that's an extreme deviation from the standard of care to fail to maintain any medical records for a period of treatment going at least 2 months?
I think it's a deviation from the standard of care, yes. But whether it's extreme or egregious, as you said, or unconscionable, I don't agree with, no.
It's not extreme deviation?
I'm sorry, but I don't know how you quantify the degree of severity in this case. I don't think, as I said earlier, which I don't want to repeat because I understand it will...
How would you characterize the deviation from the standard of care as it relates to Conrad Murray's failure to maintain any medical records in this case?
I'm sorry?
Is it minor? Is it serious? Is it extreme?
Well, I would say it's perhaps between minor and serious. It's not extreme, in my opinion. Because
do you maintain medical records in your practice when you were a practicing anesthesiologist?
When I'm in a hospital setting caring for patients, absolutely.
And one of the reasons is it's helpful to be able to go back and analyze your own notes to see how the patient had responded to past treatment, or if there are any trends, for example, in the blood pressure readings and things of that nature, correct?
Yes, having old medical records is helpful, particularly if it's a patient you're not familiar with. Previous experiences of physicians can be helpful in your subsequent management. So, yes, can be helpful.
What is the purpose of a pre-procedure assessment prior to administering propofol?
Well, the pre-procedural assessment is to evaluate the patient's overall medical condition, whether they have disease affecting other organ systems that may lead to unusual responses to propofol. It's very important to establish that the patient's medical condition is stable. That is, there's nothing, no recent changes in their medical condition. It's important to establish their airway. Are they at risk to an airway obstruction? For example, obstructive sleep apnea, a short mandible, a short neck, patients that may be morbidly obese. So the airway is very important. To establish any other factor that could accentuate the cardiorespiratory depressant effects of propofol. For example, chronic medications, cardiovascular medications used to treat arrhythmias, hypertension, and similar cardiovascular disorders.
And airway obstruction and cardiorespiratory depression are two of the most common risks associated with propofol. Wouldn't you agree?
I guess it depends. I mean, there are many risks and complications associated with propofol. It causes burning when injected into veins. But certainly the most serious, I wouldn't say the most common by any means, airway problems are fairly unusual with propofol because it, per se, unless you give very large doses or administer a dose very rapidly, it's associated with respiratory stability. Patients generally breathe spontaneously and rarely experience apnea unless it's combined, for example, with an opioid or a narcotic analgesic. In those situations is when we most commonly see the respiratory complications.
Also, other benzodiazepines, of course, correct?
Benzodiazepines tend to have more of an additive effect. Narcotics affect what we call CO2 responsiveness. Normally, when your carbon dioxide level goes up, your ventilation increases. When you have narcotics present, that response is blunted. With sedative hypnotics like propofol and benzodiazepines, they affect more the hypoxic response. That is, as your oxygen saturation declines, your ventilation increases. So that when you combine opioids or narcotics and sedative hypnotics, you get a much greater depressant effect on ventilation because they affect different components of the respiratory drive, if you will, or different arms.
Dr. White, to date, how much have you been paid by the defense for your involvement in this case?
I think I was told I've been paid about $11,000. I got a check recently, which has not been deposited as yet.
And how much do you expect to be paid upon completion of all your work in this case?
I guess if they have money, I think they have limited financial resources.
Objection, non-responsive.
Sustained. The
Motion.
answer is stricken. Disregard. Listen carefully to the question. You may ask it, please.
How much do you expect to be paid in total upon completion of your involvement in this case?
That's vague and ambiguous regarding expectations versus actuality.
Well, I'm going to sustain the objection to the characterization expect to be paid. I think you can rephrase the question.
How much do you expect to receive in compensation for your involvement in this case?
That's the same question, Your Honor.
Sustain.
You've received, you have an agreement to receive payment following your testimony in this case?
No, I do not.
Is it your testimony under oath that the only money you're receiving is $11,000?
To date, that's correct. It might be $11,200. I really don't know. My wife handles all my finances.
Is it your testimony that that amount represents the total compensation you are going to receive from the defense for your involvement in this case?
I can't say that with certainty. There are certainly some other expenses, airline trips between Los Angeles and San Francisco that I would hope to be reimbursed for.
Other than reimbursement, for your time, specifically for your time, is it your testimony under oath that the only compensation you're going to receive in total for your time put in this case is $11,000?
I hope I receive some compensation for all the time I've spent in the courtroom.
Okay, and how much compensation are you going to request?
Well, normally, you want to know how much I charge normally for court appearances?
Sure.
About $3,500 a day.
Okay.
But I have not billed them that amount because I don't think they have those resources.
And you've sat here throughout the testimony of Dr. Steinberg, multiple days of Dr. Kamengar. You've been here for hearings. You were here for all of Dr. Schaefer's testimony. I believe you've been here at least 10, 11, 12 days. About that number, does that sound about accurate?
I think that's about right. I think 6 days as an observer.
And that's $3,500 a day for all those days?
I stated that that is what I'm normally paid, but I have not billed them.
Are you going to bill them $3,500 a day for those 12 days, yes or no?
No.
Now, have you ever had a patient stop breathing after you administered propofol?
When I administer propofol for induction of anesthesia, the idea is to get them at a deep level of anesthesia so that you can insert an airway device like a tracheal tube or a laryngeal mask airway, and in those cases you may see very transient apnea.
Dr. White, I asked, have you ever had a patient stop breathing after you administered propofol? Yes or no?
I guess the answer is yes.
Okay. And what did you do to remedy the situation?
When they stop breathing, I may assist their ventilation with a bag and mask, or I may, if I'm planning to insert an endotracheal tube, I will perform a laryngoscopy and tracheal intubation. If I'm planning to insert a supraglottic device, which is a device that does not go into the trachea, it's just above the glottis, like a laryngeal mask airway or LMA device, I will insert it at that time.
So you've been able to manage the complication when someone has stopped breathing as a result of a propofol administration, correct?
Yes, as I stated, I always...
You answered the question, thank you. Can you explain for me how you would characterize the doctor-patient relationship?
Well, a doctor-patient relationship involves having a responsibility for a patient, having an understanding of the patient's medical diseases and conditions, and showing compassion for the patient, and doing your best to meet their health care needs.
And do you agree that a doctor has a solemn obligation to first do no harm to the patient?
Absolutely.
Do you feel that would you agree that administering propofol in the 2 months prior to Michael Jackson's death violated that oath to do no harm?
As I recall, in the previous 6 weeks, there was no harm. So I guess I would...
So you look at it after the fact, and if the patient's still alive, then the doctor did a good job? Is that how you analyze it?
No, you ask if he did harm to the patient.
No, I said, do you think he violated that oath? The oath being to do no harm.
I think he was providing a service to Mr. Jackson, which he had requested, in fact, insisted on.
He provided a service, correct? That was your word.
I said he provided, medical care. Let's choose that as a better word than a service.
That's a better word than the one you used?
Well, it's I think, a more appropriate choice of words, yes.
He was offered money to provide propofol on a nightly basis, correct? Based on Conrad Murray's own interview with the police.
It's my understanding that he wasn't paid any money.
I didn't ask you that, did I? You have to be very closely attentive to my questions, okay? Please, Dr. White.
I will try, thank you.
Conrad Murray was offered money to provide Michael Jackson propofol on a nearly nightly basis, per Conrad Murray's own statement to the police, correct?
I believe that may be correct, yes.
Okay. He was offered money to provide a service, the provision of propofol, correct?
My understanding is he was offered money to be Michael Jackson's private physician and to be essentially, to have Michael Jackson as his sole patient.
Who's the final decision maker when it comes to making medical judgments in the doctor-patient relationship? Is it the patient or the doctor?
I think it's a shared responsibility.
Who's the final decision maker? If there's a conflict in, say the patient requests something that the doctor thinks would be harmful and is not medically indicated, is the doctor supposed to just do whatever the patient says?
Well, the physician always has the option to walk away from the patient. That's correct.
And so you, Dr. White, if you were asked to provide inappropriate medical care that you thought was harmful to